Hello, I'm Alice Bradley.
And I'm Eden Kennedy, and we're here to talk about childbirth on Mom Ed.
Yes, and this episode is What Happens at the Hospital. And with us today is Dr. Saul Stromer. Welcome.
Thank you.
Dr. Stromer is a practicing OB. He's been so for over 20 years. It's a long time, Eden, in case you didn't know.
Yes.
He's an attending physician at Lenox Hill Hospital on Manhattan's Upper East Side.
Thank you.
Very impressive. So as you can see, we're very impressed.
Okay,
Your medical
thank you.
degree, doctor. So as you can see, I'm wearing a hospital gown because I think pink is my color, right?
It's flattering. It is.
Very flattering.
It is flattering.
And you've got on?
I have my comfy robe
Yes.
because I feel safe in it. The hospital.
You're not so into the hospital.
Cinches me up a little. Yeah, I do feel a little. It
Cinched.
smells funny. I was not comfortable at the hospital, so I had a home birth, so I
Right.
could wear my stolen bathrobe and
Yes.
have my water break on it. But it's possible I had some misconceptions about the hospital, so we'd like to ask you a few questions.
So tell us now, walk us through the whole experience. When do you, if you plan on giving birth in a hospital, when do you want the woman there who's giving birth?
I think the key to success is always, like in so many situations, communication.
Okay.
You
so don't
should
just
communicate, right, never just show up.
Okay.
You should communicate with your OB, and he or she should communicate with you. So if your water breaks, one of the questions the doctor will ask you is, was it clear? Was it colored? Is it pink? Is it green? If it's green, that's a sign that the baby had a fetal bowel movement inside, sometimes associated with stress, not always.
Dark green, light green?
Any green
Any
shade
green.
at all.
All right.
Any green.
And just in the interest of safety, no matter what you envisioned your labor experience to be, the best thing is to go to the labor floor after your doctor speaks to you to be evaluated. In that evaluation, you're going to be put on an external monitor.
All right. Is that something you strap to your belly?
Right. Strapped on, 2 monitors are put on your abdomen.
Oh.
One for contractions, one for fetal heart. Then a nurse will interview, ask you why you're there, and a resident or a physician's assistant will examine you to see, are you dilated? Did your water break? What's the position of the baby? And also do an ultrasound very often just to make sure everything is perfect.
Okay, so you're in the labor room, and tell us
What's
about
the
all
next thing that's going to happen?
Yeah.
There's machinery in there.
machines.
They
That
bleeping
machinery
machines.
is
Yes.
frightening
bleep.
to people.
Yes.
Yes.
I
They're
like
monitoring
them.
everything.
I would
Okay.
like to have them all the time, just for the record. I
Just
want
so you
to
know.
Some
monitor.
people want them all the time, and some
Like now,
people
I want
want
them.
them never. That is a monitor that tells us, is the patient contracting and the frequency of contractions?
Can't you just look at her and see if she's contracting?
No.
No. She's just like,
And
that's a contraction.
the second monitor is for the fetal heart rate of the baby.
Right.
As long as there's no medical or fetal indication to do an IV or constant monitoring, intermittent monitoring is fine. You allow the patient to walk around the labor floor, you have them come back, and periodically the fetal heart rate is assessed.
So would that be part of your birth plan?
That would be your birth plan, something that you'd be discussing in the last few weeks of your prenatal care.
Right, and I'd imagine epidural would be a big one.
Epidural is something that I always tell patients, go in with an open mind.
Right.
In the comfort of my office, it is so easy to say, oh, I'm not going to take an epidural.
Sure, right.
And the fact of the matter is, labor hurts.
Yeah.
Otherwise, we'd be calling it picnic. But there are other options for the patient who wants some pain relief and not go for the epidural, or at least not initially.
Yeah.
Okay, so it's
Like
not
what?
all or nothing.
It's not an all or nothing.
Because a lot of women are afraid that their labor will slow down if they have
And if
an
they're getting
epidural.
Pitocin, which is an agent that helps increase the intensity and frequency of their contractions, once that's going, an epidural cannot slow down your labor.
Here are some words you might hear at the hospital. Once you understand their meaning, they'll seem less intimidating. An episiotomy is a surgical incision made in the tissue between the vaginal opening and anus, or perineum, to prevent tearing during childbirth. Meconium is dark, sticky fecal matter normally present in the baby's intestine at birth and passed in its poop after birth. NICU is the acronym for Neonatal Intensive Care Unit. If there's a problem after birth, your baby may be taken to the NICU. A breech baby is positioned with its feet or bottom toward the cervix at the time of birth, causing potential problems for delivery. Frank breech is buttocks first. Complete breech is feet first.
One thing that really scared me about hospitals was the fact that it seemed like episiotomies were a routine thing. Could you address that?
An episiotomy is something that should be decided on in the last second. A tiny extension of the vaginal opening can help a patient a lot, and if sewn up properly, there should be no negative side to it at all. Where when you see those patients 6 weeks later, you don't even know that they had a vaginal delivery. As opposed to tears that could happen in 4 places, and the vagina looks terrible afterwards.
Yes, okay.
In all fairness, it can push out a baby and not require a single stitch.
Yeah.
So getting back to your comment, an episiotomy should never be routine.
Well, thank you, Dr. Stromer, so much for being with us
Thank
here
you.
today,
Thank you.
giving us all this great information.
Great information.
Well, in our next episode, we will be discussing pushing. Push that baby out. How to do it.